but I want to thank you and also welcome you to this webinar. As the previous speaker said, organized by Busoga Health Forum. We will take roughly an hour, and whoever is not speaking should mute their mics. Actually, everyone should mute their mics, and if you want to speak, you can raise your hand. But we'll be taking questions at the end of the presentation, but also we'll be following the chat to see whether there are any questions. We have an interesting topic today, and I encourage all of you to please remind colleagues that are not with us that we have started so that they also join in. Our topic today is management of cough in children. We all know cough is a very common symptom in children that present in our health facilities. But even in our homes, our children, our nieces, nephews, and in the community and in the schools, they can have cough. So it's important for us to know how to assess children with cough and manage them appropriately so that we don't overtreat or undertreat them or miss conditions that will reduce, affect their survival or their quality of life. And today is the day that we will have all these insights. So if you have questions, please write them in the chat or save them at the end if they haven't been answered by the presenter during the presentation. Our presenter today is Dr. Rebecca Nantanda. She's a very experienced pediatrician and a senior research scientist at Makerere University Lung Institute. She has done a lot of work in acute respiratory illness, especially asthma, and a lot of research in that area. But she's also my past Uganda Pediatrician Association president, and she really served us well. And as Busoga, she did a lot of work to start us up in the newborn care. Remember, especially in mentorships, and very many health workers benefited from that, and even supporting us with the tools that we are currently using to capture neonatal data. So at this moment, I really want to invite Dr. Nantanda to please share your slides and set us off. Thank you very much.
Thank you, Dr. Lauren, for the introduction, and my appreciation to Busoga Health Forum for giving me this opportunity to make this presentation. I was motivated to make this presentation by what I see as I work here at the Lung Institute. And I thought maybe we could discuss together how we can improve the management of children with cough. And I want to say that cough in children is such a wide subject, so we may not exhaust it in this 1 hour that we have. And so I'll be basically sharing some of the basic but important messages about how to try and assess children with cough and therefore be able to manage. So you may find the presentation quite simplistic. There isn't a lot of science, but I felt to discuss practical things that can help us do things a little bit differently to try and really manage our children well. And I'm hoping that by the end of it, 1 or 2 people will be able to get something which they can take home and practice better. Can I confirm with the moderator that I can be heard? Dr. Mtumba, am I heard? I want to
Yes,
confirm
we
if I
can
proceed.
hear you loud and clear.
Okay, thank you. So I'm going to talk about briefly how much is the burden of cough in the children. I'll dwell a bit on the physiology to try and understand the physiology of cough. Then we'll go into the clinical aspects where we shall look at the causes of cough, how to assess children who present with cough, and some information about how to treat children with cough. You probably already know, if you're a clinician practicing or even in the community, that cough is one of the most common symptoms in children. In fact, I would bet that most of our primary care centers, but even tertiary institutions, one of the reasons parents or guardians come to us with their children is because they have cough. And research from different areas has shown that up to 40% of the outpatient visits are actually due to cough. In Uganda, we have some information, particularly about persistent cough. So there was a survey that was done in urban setting among households who are using biomass as energy, as a source of energy for cooking. And it was found out that up to 90% of children from those households actually had cough. And this was persistent cough. But also there is a lot of evidence to show that one of the most common reasons for irrational use of antibiotics and cough syrups in children is actually cough. So it's something which we may need to discuss more to try and improve on some of these aspects that we have seen. So cough causes a lot of negative impact on the child's quality of life. For example, if a child is coughing, they will not be able to play properly. The social interactions are limited. They may not sleep. Their school performance declines. Feeding becomes a problem. Those are just a few of the things which sometimes we ignore when we are looking at cough in these children, but they are very important when it comes to quality of life of the children. But not only the children are affected, even as parents, when you have a coughing child, there is a lot of anxiety, there is a lot of stress. But besides that, a lot of money is actually spent when we are trying to manage these coughs. Some of it could be avoided only if you understood cough a little better. And so why do parents come to us? It's either because the child, apart from having cough, they have other symptoms, like they commonly will come to us when the child is coughing and then vomiting, or if they have fever, or if they have difficulty in breathing. Sometimes they are concerned that the cough has taken quite a long time to heal or unusual duration. They can compare with maybe the previous coughs. Sometimes they have a concern that maybe there is a serious underlying illness, or they think the cough is so bad, even if they may not have objective assessment, but from their perspective, the cough is actually very bad, or if it's disrupting the sleep of both care for their children. So I mention this because we need to look beyond the clinical assessment that we do. After all, they say in the body, the physical aspects or the biomedical aspects or the clinical aspects, and look at these issues that may be affecting the family or the child as a whole. And I'm thinking if we look at it this way, probably will be more, concerned and take more detailed assessment to be able to arrive at a diagnosis and give the right treatment. So what is cough? So cough is really a physiological response to any irritation in the airway. Cough is not bad always because it helps us to protect the airways, to keep them patent. So it's kind of a defensive reflex. Probably all of us have been through a situation where, you choke and you cough. In that way, the cough is just helping you to clear the foreign material. But when it gets to the coughs that are persistent, that are causing illness, then that's the bad way of the cough. But it's not always bad. It helps us to really protect the airways and to keep them patent. And in this way, it helps to prevent the entry of food or fluids into the lower airways, and therefore it can help us to prevent aspiration. But where these particles, whether it's dust or any other particle that has entered the airways, it helps us to remove these materials, especially if they are in such amounts that the mucociliary action of the airways are not able to take care of them. So somebody starts coughing to get rid of those foreign materials. It is usually a reflex, and this can be voluntary or in response to a stimulus. That's why we say that it's both reflexive and then non-reflexive. And the non-reflexive one is where we commonly have what we call the behavioral cough, which I'll discuss later. So when somebody is coughing, basically we are looking at what we call the reflex arc, and there are three pathways. So what happens when there is any irritation of the airway? We have within the airways different receptors within the epithelium, within the pharynx, the larynx, really the upper airways, but also the lower airways. We also have receptors within the stomach, the pericardium, and other areas. So what happens when there is any irritation in those areas from any source, whether it's mechanical or chemical? So there is sensation, or the nerve fibers send information to the central nervous system, which we call the cough center. This is the coordinating center for the coughs. And then the coordinating center processes information and sends it back to the vagus, through the vagus nerve, the phrenic nerve, as well as the spinal motor nerves, basically to the diaphragm, the abdominal wall muscles. And this helps to initiate the cough reflex, so the person starts coughing. And I just want probably to describe this a little more. So I talked about the triggers. This could be things like if it's very cold, if there's some chemical irritants, if there is a touch. These really activate the cough receptors like I've mentioned, and they're all in the upper respiratory tract, the lower respiratory tract, the diaphragm, the pericardium, and the stomach. And we basically have two types of cough receptors. I've mentioned the mechanical cough receptors as well as the chemical. So it may be both of them or any of them. What it does is really to activate those receptors to stimulate the reflex arc. I just tried to put this in a diagrammatic way to make it easier to illustrate, and I hope I'll be able to get this pointer. So when you have the trigger entering the airway, and when I'm talking about the airway or the respiratory tract, it includes the pharynx, the ears, the larynx, the trachea, until you reach down into the bronchi. So anything that may irritate any of those areas will stimulate these cough receptors that I mentioned, which are in the upper respiratory tract, the lower respiratory tract, the stomach, the pleura, the pericardium, the external ear. And these impulses that go to the cough center are what we call the afferent nerves within the brainstem and the medulla. And then after processing this information, then the information comes back through the efferent nerves. It's usually the vagus nerve, the phrenic nerve to the diaphragm, as well as the spinal cord nerves. And for the vagus nerve, the information is sent to the larynx, the trachea, and the bronchi. And then for the phrenic nerve to the diaphragm. And then for the spinal cord, we have the expiratory muscles, including the anterior abdominal wall, as well as the pelvic sphincter. So it's this cascade of events that eventually leads to somebody coughing for whatever reason it is. So it's that process that you go through to actually have the cough. So what are the common causes of cough in children? I want to mention that it's true that the most common cause is really infections, especially in our setting. Again, among the infections, most coughs are viral. And I want to emphasize this because I've seen a lot of children, every time they get a cough, they are likely to earn themselves an antibiotic. We actually have a saying at the Lung Institute here that if you dare cough, you earn yourself an antibiotic. almost immediately. Sometimes IV antibiotics because of the cough. But really, most of the coughs we find in children are viral. And like you and I know, viral coughs are self-limiting. Viral infections are usually self-limiting. You only give supportive care. And so there is no need for an antibiotic. But we also know that some coughs are because of bacterial infections or fungal infections, but also the Mycobacterium tuberculosis causes coughs in children. Then there are other causes like the foreign body, coughs due to bronchiectasis, inflammatory diseases like we have in asthma, pulmonary hypertension. Sometimes you have genetic conditions like cystic fibrosis. We always say that we don't have it here, but we don't know because we haven't done really research to look out for it. And we don't routinely look out for it. So probably some of these coughs we see are because of genetic conditions. But let's not forget that there are also extrapulmonary causes of cough, like if a child has heart failure, or if they have gastrointestinal disorders like gastric reflux and gastroesophageal fistula. So you can see that the scope of the possible causes of cough in children is quite wide. And therefore, when we are assessing, we need to think through these possible causes. It's not always only infections. And even if it's an infection, it's not always a bacterial infection. And therefore, we do not need to use antibiotics for every cough that we find in children. We need to make the assessment and try and arrive at a diagnosis. So those were the causes of cough. But now let's go to the type of cough depending on the duration. So every cough that is less than 3 weeks, we refer to it as an acute cough. And I know many times parents come to us and say this child has been coughing for a whole week or 2 weeks. And deep down, we think it has gone on for a long time. But for as long as that cough is less than 3 weeks, it's still in the acute phase. And then we have the subacute, where the cough lasts 3 up to 8 weeks. And then the cough, which we refer to as a chronic cough, is where we have it present for 8 weeks or more. But this is some of the literature you'll find. You'll find some other literature saying that any cough lasting for 4 weeks or more is referred to as chronic. So there is a lot of the different definitions in different guidelines, but this seems to be coming out more regularly, where we have the acute cough for less than 3 weeks, subacute 3 to 8 weeks, and then the chronic cough for 8 weeks or more. And then we can also look at cough based on the pattern. And this is extremely important. It usually helps us to guide us to the diagnosis and therefore eventually management. So sometimes we have children coming with recurrent cough. And this is the case where you have the acute cough, the one which lasts less than 3 weeks. But it comes and then there are some periods of relief for a week or so, and then it reoccurs. So that is not chronic cough, but it's a repetitive cough that comes in acute episodes. And then we can have persistent cough. This is really chronic cough and may only wane or progressively increase. In other words, the child does not get periods of relief. It just continues. It may wane a little bit, or it may just continue increasing, but it just doesn't disappear completely. So we need to find out when we are assessing, is it a recurrent cough? Is it a persistent cough? Is it an acute cough? Is it subacute or is it chronic? Because those issues or those characteristics help us to try and find out what could be the possible causes of this cough and therefore the management. So this figure tries to describe the types of coughs that I've just mentioned. So the common one is what we've said, that the acute cough. So it starts and then the intensity rapidly really rises. And then after, by usually 1 week or less than a week, then it starts really reducing and going down. But I want you to note that it may take up to 4 weeks before it completely disappears. And this is very typical with viral coughs. So if a parent comes to you and they say, my child has had cough for the past 2 weeks or 3 weeks, but it hasn't yet disappeared, it doesn't necessarily mean that this child may have a bacterial infection or something else. It may be the usual course that we expect for the viral coughs. And then we have the recurrent coughs that I described. So this is the typical recurrent cough. It starts and then it wanes, disappears to 0. And then after about 1 week or 2, it comes back again, and then it wanes. So this pattern is also very important for us to try and figure out what is going on in the airways that is causing these coughs to come and go, to come and go. And then I mentioned the persistent, the non-remitting cough, the one which starts and just continues and continues and continues. Ideally, we shouldn't wait to reach 4 weeks before we think about what is going on. This child should be really getting worse and worse and worse because it's progressing. So these are common types of patterns when we are talking about cough. But I just wanted to mention that it's important to try and tease this one out as you take a history, because each one of them may lead us to a different causative problem and therefore the treatment. Just to emphasize more that the recurrent coughs or the nasty viral coughs, there are some really viral infections that cause terrible coughs. They account for most children with isolated, recurrent, prolonged, or chronic coughs. It's just to emphasize that viral infections are really the #1 cause of the coughs, whether it's acute, subacute, prolonged, chronic. It's usually viral infections, and we shall see more about this as we continue. I decided to pull out specifically viral respiratory tract infections because, again, I find that most times children, when they have viral coughs, we either miss it out or we think they also have a bacterial infection and we give antibiotics. But also very important, communicating to their parents or guardians. They come when they are concerned that the cough is not going away, but understanding that what I would call the natural progress of these coughs can be very helpful when we are trying to reassure the parents, and so that they understand that it's not going to go away in a very short time. But I think we may start by reassuring ourselves, because sometimes it's us who are not patient and we want to keep changing this treatment. Today you start with amoxicillin. Within 3 days, you want the cough to go away. The parent comes back to you and you say amoxicillin is not working. You go higher to maybe a 3rd-generation cephalosporin oral. Then it takes another 4 days and you say this antibiotic is not working. You graduate to a cannula with IV ceftriaxone. I've seen children with cough receiving amikacin, clarithromycin, all sorts of antibiotics. So I believe if we try to understand how these coughs behave, it may help us. So I mentioned earlier that the average duration is 1 to 3 weeks. So viral coughs can actually take 2 to 3 weeks, even more. It may be persistent, and sometimes it may lead to mucopurulent secretions for weeks. So it doesn't mean that the viral infection is there, but the effect of the virus in the airway leads to these issues of persistent cough and the mucopurulent secretions. And just to note that usually when you have viral infections, cough may be the first symptom to appear, but commonly it's the last symptom to resolve. So if a child had maybe a runny nose and they had fever and maybe they were breathless or they had congestion, all those may heal before actually the cough disappears. And yet, from the parent's perspective, probably the most worrying issue is the cough and it's not going away. And we know that for viral infections, there is no effective specific treatment to reduce this duration of the cough. And so this figure just tries to clarify or to show that usually it starts and it's very bad within the first few days. This is really in days. Around the 3rd, 4th days, the child is very bad. And they tend to remain up there for some time. And then eventually, this is 5th week, it may actually reduce. But research has shown that particularly coughs due to adenovirus infections may even take longer, up to sometimes 12 weeks. So you may have a child coughing for almost 3 months. And so it's very important to appreciate this, but also look out for other possible causes of the coughs in these children that really take a long time. Now I'll quickly turn to approach to assessment of the cough. I want to emphasize that when you have a child coming to you and the mother or the caregiver says the problem is cough, as you assess this cough, your purpose or the main purpose is to investigate and find out, is there a treatable cause or not? Is there a serious underlying condition? In other words, we shouldn't take cough lightly. We should try to ask ourselves those questions. Like I mentioned, most of the coughs may not be a big problem because we expect them to resolve on their own. But it's good to ask the question, is there something that I can treat? Is there a serious underlying cause? Because some other diseases may actually present with cough. And there are two basic things that we need to do when we are assessing children with cough. A comprehensive history. You need to observe. There is a lot we pick when we observe, either the way the child is behaving, but also very important, if they're in our offices and the clinic, you can actually have a good sense of the type of cough the child is having, if the child is coughing all the time, if it's a productive cough, or if it's a dry, irritating cough. And those questions you may not even need to ask the parent because you've already observed. But also very important to take an accurate history to the extent possible. And this, sometimes parents only tell us when the cough became worse, but when the child has been coughing for some time. And that brings me to the term which is commonly used by the parents and care providers. But I also find that as health workers, we use it a lot. There is what people have decided to call a normal cough. A mild cough or a cough that is not necessarily causing worry to the parent does not mean that it is normal. It may be a cough which is not causing loss of sleep, which is not causing breathlessness, but it's been on for a long time, or it comes and goes. That is not a normal cough. So the issue of telling parents that this is a normal cough, I think it's a disservice to them because they get to believe that there is something normal about coughing, even when it has gone on for a long time. So we need to try and take an accurate history about the duration of the cough, like I mentioned earlier, and then the pattern of the cough. And of course, we need to think through what are those things that makes it worse? What are those things that makes it relieved? What treatments have you received? Sometimes they have already given some treatment that could give us a sense of what is happening to this child. And also a thorough physical examination to try and identify the possible underlying causes. Many times the physical examination may be really uneventful. You may find all parameters normal, but sometimes there are things that you find. Now, if you examine a child and you find that the general examination has normal findings, the systemic examination is fine, it doesn't mean that the child is fine, because especially children who present with chronic coughs, they may not have any physical examination findings, but when actually something terrible is going on in their lungs. So again, it's not that it's a normal cough or it's a mild cough or it's an innocent cough, like many people want to call it. You need to think through the history, the pattern to be able to arrive at a diagnosis. I just wanted to highlight or to emphasize this point. This is work which we did in Uganda here. And basically what we did was to try and understand how our healthcare workers in primary care facilities try to assess children with cough and think of the possibility that maybe we miss out some information that would otherwise have helped us to arrive at a diagnosis. And I want to point out two things from the results. So we looked at core symptoms and then history of triggers and then a clinical examination. But I want to look at the percentage of health workers that were able to just ask about the recurrence of the cough, only just 6%. So it seems like when we are looking at cough in children, we are not yet at the level where we are able to really tease out whether it's recurrent, whether it is chronic, and whether it's acute or subacute. And yet these are very important parameters when we are assessing cough. The other key finding we found was that sometimes there are certain coughs which are either present throughout the day, but there are some typical coughs that occur either in the night or early morning. In this particular case, only about 6 or 7% of the healthcare workers were able to assess for that symptom. And then very important, a little bit disappointing, because I know as a country we've tried to do a lot of IMCI training. So when you receive a child who is coughing, kindly ask the parent to remove at least the blouse or the top of the shirt so that you're able to expose the chest. We miss a lot of information when we do not do the clinical exam as it's supposed to be. Now, in this particular study, only about 22% of the healthcare workers exposed the children's chest to be able to assess. Only just about 11% counted the respiratory rate. The same proportion looked at the chest in drawing. Fewer people tried to listen for wheeze. So basically, when it comes to examining children for possible causes of cough, we're not doing great. And I want to encourage us to try and assess comprehensively both the history, but also try and do the right things when it comes to the clinical examination so that we are able to combine the history and the clinical examination to arrive at a diagnosis. So a few things that I wanted to share. What do you need to ask about the cough? Like I mentioned, when did it start? Now, this is very important. Many times the parents will tell you when they got concerned about the cough, but we want to find out when did it start, because this helps you to find out, is it a chronic cough? Is it subacute cough? Is it an acute cough? And each of those may have different causes. How did it start? Sometimes there is a clear trigger, something that triggered off the cough. Sometimes it may be, for example, when you're talking about asthma, there may be clear triggers. Maybe it was a rainy day or a rainy season, or it was exercise, or it was smoke, or it was dust. Certain things, they really help you to try and find out what could be the possible cause of this cough. And then we need to tease out what are these exposures. I've seen very many children where the cough is because their environments which trigger cough and they have underlying hyperreactivity. And so many times they've been given courses of antibiotics every now and then. And yet, if that person had taken time to just try and find out what are the exposures in the child's environment, they would be able to try and tease out that probably this is not an infectious cough. It is probably an inflammation like asthma that is causing this kind of cough. So the exposures are extremely important. Whether they're attending daycare centers or not, I know people in urban settings can testify that usually when it's school time, children tend to have more coughs. Again, most of them are viral compared to when it's not school time. Does it always start with a cold or a fever? Those are important things. What is the kind of cough we are talking about? Is it a dry cough? Is it a paroxysmal cough? Is it a wet cough? Is it a productive cough? Is there hemoptysis? These things which we sometimes ask the adults, we also need to ask them in children because they're important pointers to the possible cause of the cough. The pattern, like I mentioned, is it a day cough? Is it night cough? Does it occur throughout? Does it go away and then recur? Like we talked about the recurrent versus the persistent cough. What are the triggers and what usually helps to reduce the cough? And just to give some examples, so if you have a cough that is present for less than 3 months, and especially if it's spasmodic, disturbed sleep, probably think about pertussis syndrome. If the child coughs or an infant coughs when they are feeding, probably it's not really a problem primarily in the lungs. It could be the spilling of the feeds from the GIT into the lungs, like when we have in tracheoesophageal fistula. If the cough is happening a lot in the night or early in the morning, and then ceases after the cough ceases after a short course of oral corticosteroids, it may be consistent with asthma. And this is very important because there are some parents who come to us and they say this child coughs only in the night. During that day, they are playing, they are happy, they go to school properly. And sometimes they actually take a long time to bring them to us. But if there is this history of night or early morning cough, and then the child has been given a corticosteroids and then they improve, when we discuss asthma, you'll find out this is usually one of the cardinal features of diagnosing asthma. Some coughs which have been present, some parents may tell you that since birth, this child has been coughing. And then you need to tease out the history around the time of birth. And if this is combined with issues around chronic otitis media, probably we are dealing with primary ciliary dyskinesia. And then this one is more common in older children and adults where the cough is repetitive, but it's absent when the child is sleeping or is concentrating. This is usually a habit cough. So you'll find many adults and older children, they cough and cough and cough, but when they are sleeping throughout the night. But if you get back to the physiology of cough that I mentioned, there is no reason why they should be quiet in the night if the irritation is there because they are sleeping. So this is usually really a habit cough, or what we call a habit cough syndrome, and the management is also different. So when we are talking about the potential differential diagnosis of chronic cough in children, I'll talk mainly about chronic cough, and this can come in two ways. There are some children who have a chronic cough, but they otherwise look healthy. They are playing, they are going to school, they are feeding well, they have not lost weight. Probably are dealing with the viral bronchitis. Viral infections, like I mentioned, they come and go, but they can take a long time, up to 12 weeks, sometimes 4 weeks, 3 weeks, 5 weeks. So if the child is healthy, they had a bad cough, it's waning off, but taking a long time, probably it's a viral bronchitis cough. Sometimes you get post-infectious cough. There is sometimes what we call protracted bacterial bronchitis. So somebody may have a bacterial infection, but the effect of the bacterial infection leaves the airway quite irritated. So the cough goes on and on and on. Sometimes you may have what we call cough variant asthma. Usually these children are otherwise well. They mainly only cough in the night or early in the morning, but outside that, they're really seemingly healthy children. And then there is the postnasal drip. An irritating cough happens commonly in children with allergic rhinitis. They end up with a postnasal drip. So that chronic irritation, the drip into the airways causes that chronic irritation, and therefore they get the chronic cough. And then, like I mentioned, what we call the psychogenic cough or the habitual cough. These are really coughs, and sometimes children, when you see them, they seem like they're actually inducing the cough. So we need to be cognizant of this, because I've seen quite a number of children who have psychogenic cough, and parents are moving from one health facility to another looking for possible cause. They even do CT scans, and yet the problem is really psychogenic. And like I mentioned earlier, when there is gastroesophageal reflux, if it's not that much, usually those children are otherwise healthy, but they have that irritating cough. Sometimes the coughs really have a significant underlying cause, like when we have the chronic respiratory lung disease, like bronchiectasis, or if they have immune deficiencies. So sometimes children are coughing. So the problem is an underlying immunodeficiency. So you need to dig deep and try and find out by looking at probably other systems, the history and other things to help you. Otherwise, if you don't address the immunodeficiency and you just give antibiotics, the cough will not go away. Recurrent aspiration, like when we have TOF, like I mentioned earlier, it's not uncommon. I remember when I was an intern in ENT, I saw children who had had a foreign body for weeks and months, and they kept on coughing, and they received all sorts of antibiotics. So sometimes some of these persistent or chronic coughs are because there is a retained foreign body, and probably you need to have a chest X-ray and deal with it, and then the cough will improve. Other coughs, when we have primary serial dyskinesia, cystic fibrosis, and chronic bronchitis. So the message here is that there's some isolated cough in otherwise healthy children. These are the possible causes, whereas where there is some significant underlying cause, these are the possible causes. But this is really a small list. There are so many reasons why children do cough. So how do we treat? So if a child has chronic purulent rhinosinusitis, let me put this. In this case, would need to have antibiotics and a topical nasal decongestant. Many times we've given coughs like we are really treating acute cough. It's meant commonly see patients receiving antibiotics for 3 days or for 5 days, but usually we try to give a prolonged course of antibiotics. Usually we do 10 to 14 days. And this one usually really helps to improve children who have this chronic purulent rhinosinusitis, as well as the ones that have persistent bronchitis. If it is, think about possibility of asthma, like I mentioned earlier, you can give a try of oral steroids, not more than 5 days. Alternatively, you can give inhaled corticosteroids for at least 3 months. So you stop the treatment. If the symptoms recur on cessation of the treatment, then that's usually a confirmatory sign that actually you're dealing with asthma, and then you continue treating it as such. Then many times as part of the treatment, we may not be prescribing it, but it's very important as you write your prescription to try and think about the environmental exposures. These are the common reasons why the coughs come and go or they don't improve. And some of them may include when, for example, that study that I mentioned, when they use biomass smoke and the child is constantly exposed to this biomass smoke, or if there is a smoker in the house, or if they're in a daycare. And sometimes the only way you get a breakthrough is to address some of these issues, like if there is smoking cessation, and it doesn't do any harm to take the child out of the school for a while, just so they can have their lungs settle, and then the cough improves faster than it would have improved if they stayed in the same environment. And then specifically for the habit cough, or what we call the psychogenic cough, right now we do not know any specific treatment, but a lot of counseling and understanding really helps. So commonly it's around behavioral interventions, and there are times when we've had to refer children to the psychologist to continue talking and talking, because this is one of the difficult coughs to treat. Many times people want medication, but when in actual sense, the treatment is a behavioral intervention. Now, some issues around over-the-counter medications for cough and antibiotics. Antibiotics, if you are thinking about bacterial pneumonia, give. Chronic bronchitis, recurrent rhinosinusitis, if they have tonsillitis from strep, for example, or otitis media, please give. Do not give antibiotics for colds. Mucolytics, there are so many mucolytic syrups on the market. There is no really evidence that they help. Now, what I've observed sometimes, given the progression of cough that I've mentioned, people also start giving these syrups, and eventually through the natural progression of the cough, the child improves. And so we start thinking that's either the mucolytic or the antitussives that are actually helping. But when in actual sense, it was just the way the cough was expected to progress, given what I described earlier. Antihistamines, I mentioned that some children with chronic allergic rhinitis may have a postnasal drip leading to the cough. So when you give the antihistamines, then the cough will stop because the postnasal drip also stops. The decongestants, the cetirizines, all those decongestants there is no clear evidence that they really help in treating the cough. And like I mentioned earlier, when a person has allergic rhinitis, give the topical or nasal steroids. And also when we have asthma or viral triggered cough or wheeze, you give the steroids and observe. If they improve and then the symptoms recur after stopping the treatment, then most probably you're dealing with asthma or the viral triggered cough or wheeze. For the viral triggered cough or wheeze, this is usually in cases where somebody has underlying hyperreactivity. When we give them the steroids, whether systemic or the short course that I mentioned, or we give them inhaled corticosteroids, they actually improve. And then sometimes when they have mild asthma, again with a viral triggered cough or wheeze, you can use an alternative of leukotriene receptor antagonist like the montelukast. It also helps to relieve those coughs. So I just want to try and wind up the unmet needs and data. We need some information. I believe in the room there are a number of researchers. And one of the things which we do not know, and yet it could be very helpful to us to understand how to manage coughs in children, we need to understand the different cough phenotypes and their respective treatments. We want to understand, we have so many over-the-counter medications. Are they effective? If they're effective, in which type of coughs can they be effective, so that we stop using them indiscriminately. And then for the habit cough, that's a very difficult one to manage, but we need to find out if there is any particular therapy that can actually help us, in addition to the behavioral interventions that we give. And then if you've done some reading, there are so many guidelines on cough, but there is really no clear consensus on what is an acute cough, what is a chronic cough. And so we need to be able to unify the thinking across the globe of what is acute, what is chronic, because it has implications when it comes to assessment, investigations as well as treatment. Very important. Whereas we are saying that cough, this is really anecdotal evidence that cough is associated with a lot of healthcare costs, but we need to be able to quantify this. What is the economic burden of cough at individual level, at families and health systems? Usually this information helps us to advocate that improve diagnostics or guidelines or medications that would need. So maybe it's time for us to think about the economic burden of cough among our children and specifically in this country. Now, the last one is my own. I always find that when parents come, they are looking for that medication that will lead to a productive cough. They commonly say that I want the cough to break, and I've always wondered why. And sometimes they've also said that the healthcare worker gave me medicine so that the cough can break. I'm using the language as probably they would say it in vernacular, in the local language. And there are many times when parents have bought antibiotics for themselves, or even us, we've prescribed antibiotics so that the cough can break. Or we communicate to the parents that, why is it that we have given medication, but the cough is not breaking? And I'm intrigued by why we want the cough to break, to move from an irritating cough to a productive cough. And maybe this is something that will help us to understand what are those social issues, what are these cultural issues surrounding the understanding of cough, and be able to communicate to our parents or caregivers more effectively when it comes to the treatments that we give and what to expect. So I want to wind up by a few messages. Number one, that we need a careful, detailed history if we are to get a breakthrough to try and manage the cough. We need to identify the patterns of cough and the associated factors, the triggers, the relieving factors, the environments of the children. And of course, evaluate the patient. Like I mentioned, let's learn how to examine our patients to try and figure out what could be going on. Remember, cough may be because something is in the lungs, but it may also be because something is outside the lungs, like the cardiac, like the GIT, and other systems. And then when it comes to investigations, they are commonly indicated for persistent symptoms, or if there is a feature of a serious underlying illness. And I mention this because it's not uncommon to receive children who have received series of chest x-rays. They've had repeated blood draw to do a CBC. Some of them have even been sent to do a CT scan. Please, before you send for those high-level investigations, I would recommend that we do a careful assessment and try to find out, do I need to investigate, or am I still in the acute phase? Is there any underlying illness? That would be helpful to prevent the unnecessary investigations in our children. And then parents must be counseled that antibiotics will not cure a cough. They're always looking for that antibiotic. They've learned how to buy it for themselves, looking for that cure within a few days. We as healthcare workers were impatient. Even the parents are impatient. So the impatience from both sides makes us move from one antibiotic to the other, to the herbs, to the steroids and everything. Yet most of the coughs in children are actually viral. They may take a long time to actually get cured. And so we need to reassure the parents. And then if you're treating a cough and you have tried a certain therapy and it's not helping, just stop. Probably you're not dealing with the particular cough, or you're dealing with a cough that is going to take its own time to actually heal. There are many times when we give courses and courses or prolonged courses, when in actual sense something is not helping, but we want to try and treat or show that we are treating. So please stop the therapies if they are not, and then reassess and see, did I miss something? Why is it that the symptoms are not improving? Maybe you're dealing with something that is totally different. And lastly, reassure the parents and the caregivers. But I think we also need to start by reassuring ourselves that what we are dealing with is actually mostly viral cough. It's going to take a long time to get better. And we should be able to communicate this information to our parents to prevent the unnecessary use of medications and investigations. So I want to stop here. I acknowledge that I've used some of the slides from our colleague from South Africa, Dr. Marco Zampoli, and also our senior consultant pediatric pulmonologist, Dr. Helen Ayu. Thank you so much. Over to you, Chair.
All right, thank you very much, Dr. Nantanda. It was an excellent presentation, very enlightening, and I'm sure everyone has really learned a lot. We have a few minutes to the top of the hour, and I wanted you probably to respond to some of the questions in the chat. We'll try to go through some of them, maybe one by one. If you have then some that are similar, I'll just skip them. Joyce wants to know, she has a 2-year-old girl who's so much closer to the pussycat, and she has tried to chase away the cat, but in vain. She's worried about her child getting pneumonia. What's your comment on that?
Interesting. Maybe let me try and read them myself. It might make it easier for me to follow. So she has a daughter who is always close to a pussycat, and she's worried that the child may get a cough. Is that the question? Just trying to understand.
Yes, I think she wants to understand whether the child can get pneumonia from being closer to the cat.
Okay, so pneumonia is caused by either bacterial or viral infections. It's not necessarily that you're near or you're close to a cat, but we know that there are some types of coughs which are triggered by being in close contact with a cat or a dog, those pet animals, especially in those children who have asthma. You'll find that when you have those animals in your environment, then it becomes a trigger, and then they start coughing. And many times we ask the parents to lend the cat to another family, and then they'll see that the cough is actually getting better.
Okay.
Let me see. There's something that's not working well on my side. Sorry. Doctor, probably you could help me go through the comments.
Okay,
I have
we'll
some.
try.
Yeah.
There's a question, would Prevana 13, the pneumococcal conjugate vaccine, be helpful in prevention of recurrent coughs, especially in C class?
So the recurrent coughs in C class. So C class may have cough by the virtue of being C class, because the pathophysiology dictates that there's usually have some occlusive crisis within the small blood vessels in the lungs. And that usually leads to a situation where we have hypoxemia or hypoxia, and then fibrosis, and they end up with having fibrotic lung disease. And in a few cases, they may actually end up having obstructive lung disease. So the PCV in C class would help them to prevent the recurrent infections, the lung infections and other that recurrent lung infections, but also to understand that if they have had previous episodes of that, for example, the acute chest syndrome, even if the vaso-occlusive crisis with the vessels within the lungs being affected, they may actually have chronic coughs. And in such cases, what we do is to do a comprehensive assessment. We conduct what we call spirometry. It's a test that helps us to understand how the lungs are functioning. And sometimes we've found that they may be having what we call reversible obstructive disease, in which case they benefit from asthma medicines. Sometimes they have irreversible obstructive disease, or they have what we call restrictive disease, meaning that their lungs have been affected and they are not expanding properly. And in such cases, we want to find out if they can respond to what we call pulmonary rehabilitation. basically an intervention that helps your lungs functioning better, even though you may have fibrotic lung disease. So maybe that's what I would comment. The benefit would be there, but it would depend at what stage. And of course, we need to do the other management, which will prevent the recurrence of these vaso-occlusive crises.
All right, thank you very much. Someone is asking you to comment about the herbal usage in cough, the many concoctions on the market.
The herbs. Now, like I mentioned earlier, the type of medication you give in a cough depends on what cough you're dealing with. And I appreciate there so many times we have these herbs. I don't have any experience in the herbs, that this is the herb that treats this kind of cough. But what I would recommend is that we try to understand what is the root cause of this cough. We know that there have been some herbs, I think people have said there are some herbs where they actually add steroids, and therefore you find that the child gets better because there's been a steroid in the herb, not necessarily because of the herb. But as scientists, I think it's time for us to try and put these herbs to proper clinical trials to try and understand what is the active ingredient in this herb that is going to help us treat our children. Because you and I know that most of the medicines we use, they come from herbs, and then there are molecules that may be modified. So I wouldn't recommend a particular herb unless it has been studied and I know what is the active ingredient, because then I would know what I'm giving and against what kind of cough.
Yeah, true. Someone is asking, is there anything called allergic cough?
All right. So, and thank you for asking that question, because it's a common diagnosis. Now, from basic English, when you say something is allergic, it usually applies to at least some sort of tangible something. For example, I can say I have an allergic skin disease when your skin is allergic. So you say I have allergic skin, or maybe the eyes. Now, the cough is a symptom. And I always ask myself, how can a symptom be allergic? It's not like a structure somewhere, but to make it, I find that most times people say allergic cough, or to put it the other way around, a cough which is mediated by a hyperresponsiveness or an allergic reaction. And that is a way of trying not to be very upfront to say that I'm dealing with asthma. So I find that most time people say allergic cough, but then they prescribe medicines for asthma. So let us be confident. We know that you're talking about the pathophysiological mechanisms in the lungs, which eventually lead to those symptoms, and then you treat as asthma. I'll probably discuss that more in the subsequent presentation, which will actually be focusing on asthma.
Yeah, thank you very much. The questions are coming in very fast, which means the presentation was very interesting. The guy is asking, what's the role of zinc in treatment of cough? Is there any role?
So there have been some studies on zinc, actually in Uganda, as an adjunct therapy, means supportive therapy, to try.
Hello, can you mute? Okay.
Yes.
Go ahead.
Zinc is food. It's a micronutrient, and therefore it helps in the healing of the irritated epithelium. And there are some studies that have shown that zinc is actually beneficial in some categories of patients. It accelerates the healing process. So it's not that it's going to stop the cough. It's really trying to facilitate the process of healing of the epithelium, and therefore the irritation reduces faster.
Yeah. This you combine them together, the homemade remedies and also the role of honey in cough.
Yes, thank you. The homemade remedies, they are meant to soothe the throat. Those of you who have done IMCI, you know we talk about the honey tea or lemon tea for the a little bit older children. The they just help to soothe the throat in those cases where really the child is having problems and is having an irritation in the throat, but they are not expected to take away the cough. If you look at the physiology of the cough reflex, you need to deal with what in the first place caused the irritation to bring about the cough. So home remedies, mainly it's about honey, but I want to mention that do not give honey to the child to lick. Honey actually can induce a cough because it's very concentrated. We prefer that you put it in the tea instead of sugar. That's when the relief actually happens. So I know many parents, when we say honey, give honey, they give it directly and then the children continue coughing. It's better you put it in tea and then the child takes it.
Yes. Also, someone has a question on hypertonic saline for irritating coughs, nebulizing with hypertonic saline. Is there a role?
So hypertonic saline can be good, but can also be dangerous if not given correctly. So what happens, or the indications where we use hypertonic saline, if somebody is having a lot of mucus in the airways, especially if it is thick mucus. So what hypertonic saline does is to help, if you nebulize, is to help make the mucus thinner and also helps the cilia to bring it a little bit up more into the throat, and therefore the child is able to cough it out. But we also know that if you give hypertonic saline, it can cause bronchospasms. And so before you nebulize with hypertonic saline, it's usually recommended that you first give a bronchodilator and then nebulize with the hypertonic saline. And then you can have the child have less thick mucus and be able to cough it out. And this principle, we also use it when we are dealing with, when we are going to do sputum induction for various investigations, including children with TB or pneumonia.
Yes, Isaac is asking, is there a role of steroids, hydrocortisone, in the management of pneumonia?
No. So steroids are anti-inflammatory medications. If you get back to the basic pathophysiology of pneumonia, first of all, pneumonia, the problem is within the alveoli, or what we call the lung tissue. They get inflamed, they swell, there is an exudate, sometimes leading to pus. And that's what brings about the stiffness of the lungs and therefore the symptoms. Now, steroids are only indicated when you have what we call an inflammatory response within the airways. And that's usually in the cases of asthma. Like I mentioned, we give steroids for children with asthma, but we also give it in children who have what we call the viral-induced wheeze, but when we have evidence that they have underlying hyperreactive airways. That is the only role where steroids would be helpful if you are looking at the lungs. And then sometimes you also give, if they have acute laryngitis or they have the croup, because of that acute and severe inflammation, sometimes children are so breathless because of the inflammation, we may give a short course of the steroids. But it's not that every child who has respiratory symptoms should be given steroids. So you need to assess the children and decide whom do you want to give steroids and whom you may not give the steroids.
Thank you very much, Dr. Nantanda. I think it's coming to 9. We'll just take one or two more from the chat and then invite Professor Peter Waiswa to give the closing remarks. So the person wants to know what's the relationship between pneumonia and coldness. There was also a person who commented on parents over-covering children when they have a cough. You can take them together.
Okay, thank you. So the link between pneumonia and cold, I want to believe that you're talking about cold weather and not a common cold. So this usually is something that is observed in some of the countries where they have seasons, that you have these respiratory infections happening during particular seasons. and not during other seasons. But in our setting, what sometimes people call pneumonia is where a child has a cough and has difficulty in breathing during cold weather. And that is completely a different disease where you have the trigger as cold. Probably you're dealing with asthma and not pneumonia. Now, the symptoms of pneumonia are very similar to the ones for asthma. They have cough, they have difficulty in breathing, they are breathless, they have chest indrawing, and many times these children don't even have the wheeze. And therefore, many times they're diagnosed as having pneumonia instead of asthma, and they're treated with antibiotics. So that is the link that I can say. And because there is that issue of the cough worsening or the symptoms worsening when there is cough, then you'll find that when parents cover their children when it's during the cold weather, then the breathlessness or the symptoms are not as bad. In fact, we usually recommend that when children get those symptoms and they have asthma, you cover them, they keep warmer, and of course with the medication, then they are able to improve. So maybe that's the link that I would like to mention about the seasons, but it's not necessarily that the cold as it is, cold weather leads to the pneumonia. It's usually what happens in the lungs when it is cold or in a cold day.
Yeah,
I think that's that. I just wanted to mention before maybe Professor Waiswa comes in, there seems to be quite a number of questions. I saw some questions that are related to asthma. I'll hope to have an opportunity to make a presentation that is specifically going to be focusing on asthma, maybe 2 or 3 weeks from now. If you have any particular questions, maybe you can send them to the secretariat so that when we are making a presentation, we are responding to your needs. So it's not that we shall not answer them, but we'll have an opportunity to answer them in the presentation that will be coming in a few weeks' time. Thank you so much, Dr. Mtumba. Over to you.
Right. Thank you very much, Dr. Nantanda. Lots of comments really thanking you for the presentation. People have enjoyed it, and I hope that will reflect in how we perform our duties and how we assess children with cough. So at this moment, allow me invite Professor Peter Waiswa to give some closing remarks and also close this webinar. Over to you, Prof. Professor Waiswa, are you there?
Yes, I'm here. Sorry, I was failing to unmute. Thank you so much, Dr. Rebecca Nantanda. I must say that it's a very nice presentation. You could think about cough as being very simple, but then you unpacked it, and yet it's a very common thing, and we need to treat it well. Thank you for doing it. As your former classmate, I felt so proud about it. And thank you for supporting Busoga Health Forum and working with us. Come back again. Thank you, Rebecca. And I'm sure there is going to be a small token from Busoga Health Forum. Please receive this token of appreciation. Thank you, Dr. Rebecca. And Roland, thank you for being the pediatrician in my home district, but also the hospital I was born, Iganga. But of course, most importantly, for chairing this session. Please also receive this certificate as a token of appreciation from Busoga Health Forum. Thank you.
Thank you.
And for the rest of the members, please, thank you for coming. Have a good night, good weekend, and see you next Friday. Go and do a good assessment of coughs and don't misuse antibiotics. Bye-bye.